Good morning. My name is Muranja. I am a dual certified family nurse practitioner as well as a primary mental health nurse practitioner. Today I'm honored to present my quality improvement project about reducing readmission rates in psychiatric patients. I want to take this opportunity to thank my chairperson, Dr. Davis, for her guidance, patience, and unwavering support. All the other faculty at Maryville University, your support is also greatly appreciated. Background. There is a growing pressure to lessen the burden of care to psychiatric patients because of the increasing cost of containment to the government, insurance providers, and families. Similarly, the need for change necessitates the adoption of improved discharge planning in psychiatric facilities. The aim of this quality improvement project is to determine if an educational intervention improves compliance of discharge planning and reduce hospital readmission rates. The goal is to improve the discharge process for patients with psychiatric disorders from the inpatient settings that transition to the outpatient setting. Psychiatric disorders that necessitate hospital readmissions are common. In the United States, nearly a fourth of adults suffer from psychiatric illness, and that is according to National Institute of Mental Health. A lack of proper discharge planning and connection to community resources results in frequent readmission. Discharge planning guides healthcare providers to sustain improvements achieved during patient treatment in the psychiatric unit. Likely, inadequate discharge planning is the greatest obstacle in healthcare, as it causes disruption in patient care. For this reason, the patients may still require relapse prevention group, mental health services, and continued counseling. Readmission rates may be decreased by combining timely discharge plan, transition plan, relapse plan, and a follow-up plan with the outpatient services to assist patients through the aftercare. A lack of community resources, appointments with psychiatrists, community counselors, therapists, and lack of family or social support contributes to higher readmission rates. And that's why it's very important to have some good community resources before the patients are discharged. Continuance of literature review. The studies by Habit et al., Jaramillo and Herazo, they indicate that many patients have had severe problems after being transferred to community settings. This leads to several psychiatric emergencies, referrals, and readmissions. Evaluation of the community to fit patients' need is also critical in reducing readmission rates. In addition, Wang et al. Also believed that the evaluation of available services within the patient's accommodation area will assist in the best match for the patient's needs. Literature review continues. Even though hospital readmission could be results of the severity of psychiatric illness, authors like Fuller et al., Shinjo et al., Axon and Williams, they argued that ineffective inpatient care and lack of observance with outpatient care are among factors that contribute to the hospital readmission among psychiatric patients. Readmission of inpatient has significantly reduced the quality of life and snowballed the years of lost life. Besides, hospital readmission is linked to community resource constraints, including employment and residential status. In addition to Jaramillo, he indicated that 33% of patients admitted to psychiatric conditions, they will probably be readmitted within 5 years. The study findings that the Marcus et al. Conducted a longitudinal cohort analysis of database among patients with schizophrenia or bipolar. General and stratified linkage was studied between visitations of an outpatient follow-up appointment within 30 days post-discharge, as well as hospital rehospitalization within the 31st day to 120 days. The study finds that outpatient visitation during the 30 days after the patients were discharged were linked with less rehospitalization risk within the 31 days of the 120 days. The research concluded that there is a need for an assertive discharge planning process to secure patient visits for these patient populations. The aim of discharge planning include helping the patients enter the community, supporting and sustaining the care started during inpatient care, attaining care continually and coordinate of care, treating and offering the level of support that links to what the patient would need for community living. Theoretical framework. Self-care deficit theory by Orem's self-care nursing theory was used in this study. This model focuses on lessening the self-care shortfalls of patients with psychological conditions by enhancing their self-care agency, meeting their therapeutic self-care needs, and creating therapeutic self-care system. Additionally, Orem's fundamental illustration is when she contends that nursing is a crucial aspect of enhancing self-care action. The provision and sustenance of it should be continued to support human life and health, recuperate from illnesses, and manage their effects. The circumstances that authenticates the actuality of the need for nursing practice in an adult is the lack of the capability to sustain for themselves and lack of continuous quantity and quality of self-care, which is a therapeutic in maintaining human life and health in recuperating from illness or in coping with their impact. The methodology. A quantitative explanatory design through a retrospective chart review was used. Electronic medical records data from the hospital with no patient identifiers were utilized. In the study, minimum necessary data was collected for analysis. Inclusion criteria required participants to be 18 years or older and that they were hospitalized within 30 days of discharge for a month. Another inclusion criteria that are required for all patients to be from all cultural backgrounds. Exclusion criteria. Participants under 18 years and not being hospitalized within 30 days of discharge. The researcher recorded the minimum necessary data to accomplish the goals for the project on the data collection sheet. All potential patient identifiers, as I had said, was removed. Methodology checklist, an outline. After IRB approval was obtained from Maryville University, the data collection process began. The medical director provided the researcher with a written list of patients who were admitted within the last 30 days of discharge. The researcher used her employee protected password to access the EMRs. The written list was stored in a locked file cabinet in the researcher's locked office that could only be accessed by the researcher during the data collection period. The data constituted the minimum necessary data to accomplish the goal of the project. After the completion of the data collection, the researcher returned the written list to the medical director. And the data collection stopped when the researcher had reviewed 103 data charts. Continues of methodology. All data was manually exported to Statistical Product and Service Solution (SPSS) and analyzed using a z-test. Focus was on integration of community resources available and education of medical personnel. It also considers the patient's ability and knowledge of illness, assessment of patient's needs, socioeconomics and cultural factors that may cause patient relapse. Qualitative methods used included proportion, odd and risk ratios, and chi-square test of association. Sample. A sample of 103 charts were reviewed from the hospital EMR system. Inclusion criteria desired that all participants of 18 years or above and that they were hospitalized within 30 days. Another inclusion included that all patients had to be from all cultural background. Exclusion criteria: participants under 18 years and not hospitalized within 30 days. Data analysis. All data were exported manually to Statistical Product and Service Solution, the SPSS, and it was analyzed using a z-test. Assessed interventions included discharge and community resources checklist, follow-up, appointments, 30 days medication supply, and medication reconciliation with the nurse. Discharge checklist had readmission rate of 56.9%, which was not significant, having a 47.8% of adherence. In terms of community resource, checklist was 51.3% readmission rates, which was not significant compared to 54.7% who were discharged without community resource checklist plan. A follow-up checklist had 48.8% readmission rate, which was not significant, having 56.5% with no follow-up checklist plan. A 30-day medication supply intervention showed 53.7% readmission rates, which was not significant compared to 57.7% without. Nurse medication reconciliation indicated 53.7% readmission rate, not significant against those without. No significant relation between readmissions and any intervention plan. High chances of readmission seen in odd ratio with readmission rate of 1.5. All the p-values were statistically non-significant. Results. From all the charts reviewed, 53.40 were readmission cases, while 46.60 were not. Discharge checklist was followed in 55.34% of the charts. Community checklist was available in 37.86% of the charts. Medication reconciliation with the nurse was done in 92.23% of the chart samples. Results. Follow-up appointments were done on 39.81% of the cases, while 74.76% of the sample received medications for at least 30 days. Medication reconciliation with the nurse was done in 92.23% of the chart sample. And that is the z-test table. Limitations. Several limitations were noted in this study. First, the data collected was limited to only one hospital in the urban area, and therefore the results may not be the same as a rural hospital. Secondly, the staff intervention was done during the COVID pandemic, hence only a few staff members were able to attend. There was no time to reschedule the staff members who missed the session. The study focused on a design approach to analyze data of psychiatric patients discharged not earlier than 1 month from the day of the data collection. As a representation of the whole, The data used in the analysis process might have not captured the trends in readmission of psychiatric patients in times earlier. The data was analyzed on only one urban hospital. Therefore, the generalization could be limited for other psychiatric facilities. The future recommendation is perhaps the researcher should explore other possible factors that would affect readmission rates and extend the research to even rural psychiatric hospitals. The overall purpose of this study was to determine if staff adherence to discharge planning protocol and reduce hospital readmission rates. The findings suggested the estimate of readmission rate was 53.3%, which means that slightly more than half of the discharged psychiatric patients ended up being readmitted within 30 days of discharge. Conversely, the study found no evidence of a difference in readmission rates between cases where the discharge checklist was strictly adhered to those cases where the discharge checklist was not adhered to. Discussion. In contrast to the findings of earlier studies, Jaramillo Gonzalez et al. And Randy Shinjo, they had estimated a 5 years of readmission rate of 33%. By comparing these estimates, we see psychiatric readmission rates surged by at least 20.3% just in a couple of years. This also contradicts the finding of Wong et al. That indicate that discharge planning and procedure planning affects the readmission rate. The planning involves consideration of patients' need as well as existing community resources. This consideration is also supported by the findings of Cowley et al. And Taylor, who argued that rehospitalization has financial, emotional, and practical burdens that lessen social contracts and social support. According to Guzman, Parral et al. And Vasudeva et al., patients have had severe problems after being transferred to community settings, leading to several psychiatric emergency referrals and readmissions. Implications for practice. This study will increase the knowledge among nurses on discharge education. It will equip the nurses and other professionals with skills that are mostly overlooked in the normal system of education. With a plan for discharge process among patients, quality health care will be achieved. Implications for healthcare policy. Add the healthcare policy concerning the discharge planning to guide providers of healthcare on sustainable improvements. Implication for quality and safety. It will help with the plan for discharge processes among patients. Quality healthcare will be achieved. Conclusion. The purpose of this quality improvement project was to determine if an educational intervention would improve compliance with discharge planning and reduce hospital readmission rates. There is a growing pressure to lessen the burden of care to psychiatric patients because of the increased cost, which adds a burden to patients. Therefore, it is critical to continue assessing causative factors that result in high rates of psychiatric readmissions. A proper aftercare plan should be planned with confirmed outpatient appointments, medication reconciliation with the nurse, and 30 days medication supply to last until the next appointment. Accordingly, all stakeholders should continue to develop discharge planning suitable to each patient. Moreover, the current discharge protocol should be revised and updated according to current discharge plan recommendations that are evidence-based. This can be achieved by continuous adherence to discharge plans and preemptive discharge care planning, promptly when patients are admitted. As I said, discharge plans should start from the time the patients are admitted until the time they are discharged. As a result, the discharge should continue after the patients are discharged home. Future recommendations. Future recommendations include assessing other factors that might contribute to increase readmission rate more than just adherence to current discharge protocol. Few potential factors that could be considered for future studies include assessing patients' comorbidities, severe mental illness that may require long-term injectables, lack of insurance, poor support system, and chronic homelessness. In addition, follow-up phone calls to patients should be considered to ensure aftercare follow-ups to their outpatient providers and medication compliance to decrease early readmission. Any questions? Thank you so much for listening. And the other slides, it's all about references. Thank you.